about all the things we do. Just to give you a very, very brief background, because my mother always makes me talk about myself for a couple of minutes. We have a little physician vehicle on the road 24/7, which is an ER and operating room on wheels. We can give blood. We have a bone saw. We have all these kind of cool things. We have an ultrasound machine, so ultrasound machine will ultrasound people pre-hospitally. We consider our group of people called EMS physicians. Nowadays, you can be board certified in emergency medical services, just like cardiology or gastroenterology or anything else. I tell people that, it's no wonder that emergency physicians who work in ERs know very little about EMS, because the average ER residency, 3 to 4 years, you only get 6 days of EMS experience. So it's no wonder that emergency medicine doctors don't know that much about what we do. And in fact, now there's a board certified specialty, so we can go ahead and we can teach people. So we're on the road 24/7. We have 2 vehicles. One's a marked light to siren vehicle. We'll go anywhere in the state of New Jersey. And the other is an unmarked police car, because we provide all the medical support for the New Jersey State Police and go in all the barricades, no-knock warrants, in an unmarked Crown Vic P71 police car. So we're really busy, but we love going to do outreaches. And we're going to talk about all these things. There's usually a few people who say, I've never heard of what you're talking about. That's crazy. That makes no sense. So I would say in this lecture, it's important for you to just keep your minds open. Because although what I'm saying is may sound very strange, there's somewhere in the world where people are doing this in EMS systems. You may never have heard of some of this. Somewhere in the world does this every single day. And, what we talked about is being on the cutting edge. I'd rather be leading the group than being behind. We publish about 60 papers. We currently have some NIH funding. So we believe in changing things as they change. And I tell people, if you go by what's in the textbook, you're probably going to be 3 to 10 years behind the current way of thinking. But we now have all these social media things. So I have a physician who does social media. So we have a Twitter account called Crit Care Anywhere, which is C Care Anywhere. So if you, and I never twitted, or whatever it's called, I never did that until a couple of weeks ago, and now we have a whole bunch of followers from all over the world. So we do like tips of the day. We will pull up the latest medical stuff, and the whole site's just for medical stuff, nothing else, not to discuss any operations or the good part of the day, the bad part of the day. So we just discuss that. And as of last week, we got a blog, which is ccareanywhere.blogspot.com. Does that sound right? All right. C-Care. So I guess there's too many characters, so we couldn't make it Crit Care, so we had to make it C-Care Anywhere. C-Care Anywhere. And it's basically, our concept is we're connecting the ICU to the emergency department to the pre-hospital setting. So we're all doing the latest stuff together. And part of this lecture is basically about doing the latest stuff. And we do really things that you may consider to be quite crazy. We do hands-on defibrillation all the time, which means when somebody's ready to be shocked, we do not take our hands off. We do not say clear, because clear to me means go away. And I don't want anybody going away. And I'm going to present lots of statistics and lots of numbers to you, but I only want you to remember one thing, and it's from a paper this year that will be in ACLS in the next 5 to 10 years, because ACLS is a 5 to 10 year process, but only one number. For every 5 seconds you're off the chest for someone in cardiac arrest, survival goes down by 7%. That includes anything. That includes intubating. That includes moving the patient. That includes the shocking time. So certainly, there should be no argument that when somebody's intubating, you can't stop compressions. Somebody says, I just need to stop compressions for a couple of seconds. And I say, sure, we're going to decrease this person's chance of surviving by 7%. If that's okay with you, then stop compressions while you intubate. That's never okay with me. Certainly, while the defibrillator is charging, we need to continue compressions. That's not even debatable anymore. When it's analyzing, there are now devices where you can do see-through CPR, which means you can actually do compressions while the machine is analyzing. Now, life packs generally don't have this function. Zols do. Eventually, all the defibrillators and monitors will. And certainly now the next step, which is what we're doing, is we actually do compressions while the machine's analyzing. And if you look at the data where people got hurt, the data is all when people took the paddles and put it on somebody's chest. And if you look at the data when you're using pads, it's incredibly safe, incredibly safe. In fact, what we're doing now, and we're starting to do this, is what's called double sequence defibrillation. I don't like that term at all, but that's kind of the name it's getting in the literature. And it means we take 2 LifePak 12s or 15s or anything you have, we put 4 pads on a patient, and we press both simultaneously. So we shock with 2 defibrillators at once. This is now getting to be in the throwaway literature, not even the popular literature, called double sequence defibrillation. So we're shocking at 720 joules, and we're still keeping people on the chest doing compressions. Because who's to say 360 joules is the right number? I don't know that. That was kind of made up in the literature. Maybe it's 1,400 joules, maybe it's 2,000 joules. We just don't know. So this is kind of interesting. So I'm following this literature pretty closely. We don't know that there's better outcome studies with 2 defibrillators doing 720 joules. However, what we do know is we have more return of spontaneous circulation in the studies. We have better end-tidal CO2s in the studies. We just haven't correlated that yet with better survival rates, with better walking out of the hospital alive. So we're all following this literature pretty closely. So most people now are recommending double sequence defibrillation for a refractory VFib. Like, don't do it the first time you're shocking VFib. But for me, I tell the paramedics after this 3rd time, when you're ready to shock for the 3rd time, that's when I want you to do double sequence defibrillation. And people keep reporting to me, you know what? We couldn't get the guy out of VFib. We shocked him with 2 defibrillators, and he came out of VFib. We don't have good literature yet to say you're better survival, but we have good literature to say you're better return of spontaneous circulation. I'm paying attention to this literature because I think this may be what we've been waiting for. We'll see. So the whole lecture tonight is going to be about one thing, and that's how to save a life. As how to save a life by the best evidence in cardiac arrest, by the best resuscitation evidence. And just think about this. Here's this person. Can you all see that? I don't know if you can see the nose. There's a nasal cannula in this. So I was a paramedic for years. I used to take people who were critical. Some of them would be on CPAP. Some of them would be on non-rebreathers. They were doing worse and worse. And then I would take them off the non-rebreather, and I would put a laryngoscope in the person's mouth. Isn't that crazy? The people who were the sickest, who need the oxygen the most, I was giving them no oxygen when I was intubating. And somebody in 2010, this guy named Levitan, in 2010 wrote an article called No Desat. And what he said was, people in this stage should be on a nasal cannula at least 15 liters per minute. So if anybody ever taught you you can't give more than 6 liters per minute by nasal cannula, that's totally wrong. That's not based upon any science. That's incredibly wrong. Everybody, I'm going to tell you, everybody who's critically ill should have a nasal cannula on at least 15 liters per minute. And so you need another tank next to the patient. That's totally fine. And this serves many, many purposes. The simplest one is it provides oxygen while you're intubating. And you're going to say, but the patient's not breathing if they're in cardiac arrest. I'm going to tell you it doesn't matter. If somebody is breathing, the alveoli absorbs oxygen roughly about 200 to 300 milliliters per minute. But if they're not breathing, it's about 3 to 5. So they're still getting oxygen absorbed across the alveoli, even if they're not breathing, if you provide it to them. So this is really, really important. And I'm going to tell you, if you have CPAP on somebody's face, put the nasal cannula on underneath. So if they decompensate and you rip the CPAP off their face, you still have the nasal cannula on every single moment. So every single moment they're receiving oxygen the entire time. Now we're going to talk more. There are other reasons why this is really important, but this is nasal cannula. There's more and more literature now. There's 5 published papers. The first paper was called No Desat, and I'm going to tell you that when you're intubating these patients who are on high-flow nasal cannula, and the literature's kind of dubbed this HFNC, high-flow nasal cannula, they're not going to desaturate. It's the weirdest thing in the world. They're going to keep their sats up. Now, not everybody. Certainly some people in pulmonary edema who are hypoxic, they may not maintain their sats well, but that's because they're really sick. But you're going to see a lot of people not get worse because of a simple, simple thing. So when you're putting that CPAP on somebody, put the nasal cannula on underneath every single time. On our charts in our EMS system, the medical director for Monaco, the largest EMS system in New Jersey, we actually put it on the charts. So if the paramedic does not put a nasal cannula on somebody, we actually ask them why they didn't. We do this now for BLS. We go around telling BLS, every time you have somebody sick or is being intubated or might be intubated by ALS, put a nasal cannula on at 15 liters at least. And 15 liters is a minimum, So we put it on really high, and we want to improve oxygenation. High flow nasal cannula is just some of the background. Levitin wrote the first paper in 2010. There's five actually more papers out. So you probably learned that bagging people is a good thing. I'm going to tell you there's nothing worse you could do for a patient than bag them. Let me be even more specific. The most dangerous thing you keep on your ambulance, whether you're ALS or BLS, is the BVM. Not the medications, not the defibrillator. The BVM is the most dangerous thing in the world. And here's why. Bagging people hurts people for 4 reasons. It actually increases mortality. So if somebody's not breathing, you have to bag them, right? That's a no-brainer. That's pretty obvious. But if somebody's breathing at least 4 times per minute and their pulse ox is at least 90%, you do not need to bag them. In fact, you will make them worse. Here's why. 4 reasons. The simplest reason is if somebody's being bagged, right, they're going to open up their lower esophageal sphincter, the connection between the esophagus and the stomach. And what's going to happen to these patients? They're going to vomit. So it's going to make it more difficult to try and intubate them because they're vomiting. The weirdest thing is if you stop bagging these people, much fewer patients are going to vomit on you while you're intubating. We do this on a regular basis. We have almost no patients anymore who vomit on us. It's the weirdest thing because we're hardly bagging anybody except if they're totally not breathing, except if their respiratory rate's less than 4. And if your respiratory rate's less than 4 and your set's less than 90, we just bag you up to those numbers. And once you reach those numbers, we put you back on a non-rebreather. All right, so the vomiting issue is easy. The other reason bagging is bad is it causes shunting. So your whole goal in life is to improve oxygenation through the alveoli, right, to get more oxygenation. So think about this. If you take a BVM and you put on somebody's face and you attach 100% oxygen to it and you don't bag, how much oxygen do they get? None. If you don't squeeze the bag, you get no oxygen. Now, when you squeeze the bag, then the alveoli opens and you oxygenate. And in between squeezing the bag, what happens to the alveoli? It collapses. What happens when the alveoli collapse? So the goal is to keep the alveoli open during the entire oxygenation period. How do I keep the alveoli open during the entire oxygenation period? I take a PEEP valve and I put it on my BVM. Every BVM should have a PEEP valve on it. If you do not have a PEEP valve on your BVM, I'm ready to say in 2014 you are doing the wrong thing. Now, it's the BVMs where the PEEP valves come with them are generally very expensive, so most ERs and pre-hospital don't have them. But maybe with your CPAP, you have a PEEP valve that came with it, or you can just buy PEEP valves for only a couple of dollars. Every PEEP valve, every BVM must have a PEEP valve. So think about this. You bag somebody, the alveoli opens. In between bagging, it collapses. You don't oxygenate. And that's the exhalation period. So how do you keep that alveoli open so you can oxygenate during inhalation and exhalation? All you have to do is attach a PEEP valve to your BVM. And you do this every single time. Now, the other thing that's really helping you is that nasal cannula, because that positive pressure oxygen via the nasal cannula with the PEEP valve is letting you oxygenate during inhalation and exhalation. Right? So 2 things that will save lives, nasal cannula and the PEEP valve on every single BVM. Because if you only want to oxygenate during inhalation during half the cycle, then don't listen to me and don't put a PEEP valve on. But if you want to oxygenate during the entire process, then put a PEEP valve on every BVM with high flow nasal cannula and you'll oxygenate during exhalation. This is just like wearing a CPAP mask. CPAP keeps your alveoli open the entire time. In fact, when you put a PEEP valve on your BVM, and you use nasal cannula at 15 liters per minute, all you're doing is you've created CPAP for the patient. That's what you've done. And just think about this. This is why these people do really well. There was just a big study in New England Journal of Medicine which said people who have obstructive sleep apnea who use CPAP machines Should we be giving them oxygen, right? Because most CPAP machines, in general, for most people around the world, well, not all, don't give oxygen. So there was a study where they added supplemental oxygen, just like 2 and 4 liters, to CPAP. And you know what it showed? We don't oxygenate any better, right, if somebody's oxygen isn't below 90%. What that basically means is the concept of keeping the alveoli open is even more important than the concept of oxygenation. So the positive pressure from the nasal cannula with the PEEP valve will let you oxygenate during exhalation, and you will save more lives, right? And if you look at some of these countries, like Sweden just reported their data like a couple of weeks ago. They doubled the return of spontaneous circulation and doubled the survival to out-of-hospital discharge. So what are the other reasons bagging is bad? Well, bagging tends to over-distend this alveoli. And when you over-distend the alveoli, you compress the capillaries around it, and you oxygenate less. So those are 2 reasons it's bad. Another reason it's bad is you actually decrease blood flow through the venous system in the cerebrospinal area, all the way to the brain, because it's a valveless system. And when you decrease blood flow there, you actually decrease blood flow to the brain. So you're getting less blood flow to the brain when you're bagging. And the most important thing of all the 4 reasons is the last one. And the last one is you increase negative intrathoracic pressure, you decrease preload, and you decrease myocardial blood flow. So when you're bagging, you get less blood flow to the heart. You get less blood flow to the heart, you get less blood flow to the brain, you get more shunting, so decrease oxygenation, and you open up the lower esophageal sphincter, and you make people vomit, and you make people aspirate, and you decrease the chance of them walking out of the hospital alive. So am I telling you not to bag? No. I'm telling you that if they're breathing less than 4 times a minute or their SAT's less than 90, you got to bag. And you bag, and if they're not breathing at all, you'll continue to bag. But if they're breathing at all, at least 4 times a minute, then don't bag. Slip them on either 1 or 2 things, either non-rebreather with the nasal cannula underneath or CPAP with the nasal cannula underneath. And I always prefer CPAP when I can get it. Make sense? Much less bagging. You know, this is Scott Weingart. Scott Weingart does a lot of interesting things. He came from Sinai, now he's at Stony Brook. One of my residents is going to go train with him for a year come July. And he's been saying this, and I think it's one of the papers. I always tell people that if you can only read 2 papers because everybody's really busy, this would be one of the 2. This is an article by Weingart, and it talks about lots of stuff I'm saying right now, which is pre-oxygenation and how to prevent people from desatting and emergency airway management. And he goes over all these things. Another thing he mentions in the paper is how to intubate. And every time you intubate, the head of the bed should be up at least 30 degrees unless you're intubating a cardiac arrest patient. So if the patient's not in cardiac arrest, meaning you're doing compressions, you have to intubate with the head of the bed at least 30 degrees. You're improving myocardial blood flow, you're actually augmenting preload, you're oxygenating better, you're moving the diaphragm further down, so the head of the bed stay up, and you decrease aspiration pneumonitis. So the head of the bed should be at least 30 degrees every time you're intubating. Lots of studies. So this is not new. There's lots of literature that talks about worsening patient outcomes by bagging excessively. So bagging, and this is why these threshold devices became very popular initially. One was because of the changing intrathoracic pressure, but 2 was just because we were telling people how quickly to ventilate, because the truth is, we all bag way too fast. It's common to do this when you're not paying attention to it. This is why end-tidal CO2s are really, really important, because they tell us to slow down. The number 1 thing I do on this scene, we go on about 30 calls per week on average. And the number 1 thing we do on the scene, to mostly BLS, not ALS, is we tell people to bag slower. And the end-tidal CO2, because when end-tidal CO2 is 8, my first question is it 8 because the left ventricle is not working very well because the patient's really, or is it 8 because we're bagging too fast? So I tell people, slow down the bagging. And bagging should be slow. And the best literature now actually says you should be bagging somebody in cardiac arrest about 4 to 8 times a minute. And ACLS and CPR will catch up to that, but it's lower and lower and lower. And that's actually the best science. So when we start bagging less, it actually, the end-tidal CO2 comes up, and it may mean that it's time to transport the patient. So the best study came out this year, which told us when we should transport a patient. The biggest study ever. So what % of people who have a cardiac arrest pre-hospitally and you don't get a pulse back in the pre-hospital setting, what % will walk out of the hospital alive? The biggest study came out this year. So we've all had these different numbers. So again, we'll ask the question. Cardiac arrest, you don't get rust pre-hospitally, and you're going to transport the patient. You make the decision to transport. You work on the patient, and you're going to say, now we have to go, because we've been here too long. But I'm going to try and tell you that maybe objectively, we can figure out who we should pronounce dead and who we should transport based upon some science. The biggest study came out this year, and it said 9% of patients where you don't get ROSC pre-hospitally will walk out of the hospital alive. 9%. So now the next question is, how do we figure out who that 9% is? And the answer is, it's not easy. The one thing we can measure, there's 4 different ways, but one important measurement is the end-tidal CO2. If your end-tidal CO2, and this could be good for ALS or BLS, if your end-tidal CO2 is less than 10, after 20 minutes of resuscitation, your chance of walking out of the hospital alive is 0 by 4 studies. All right? Pretty simple. Your end-tidal CO2 is less than 10 after 20 minutes, 0% chance. So basically, if somebody, if you get to a nursing home and somebody says, oh, that person has been in cardiac arrest for 30 minutes, there's no chance of survival, you get an end-tidal CO2 of 30, my first response is, no, they haven't. Nobody's dead for 30 minutes with an end-tidal CO2 of 30. That's not realistic. That doesn't actually happen. That means that maybe they weren't breathing well, or they were hypoxic, or maybe the respiratory rate was 2 or 4, but they weren't actually in cardiac arrest. But 4 objective studies. If you're in the scene with somebody pre-hospital and your end-tidal CO2 is 10, and they're in cardiac arrest, and now they're 30 and they're in cardiac arrest, I don't know what you're doing, but you're doing something good, right? Keep doing it. So those are people I want to transport to the hospital because we're improving their left ventricular function because their end-tidal CO2 is getting better, right? I don't know that moving them to the hospital will be any better, right? Because the one thing the literature says is once you make the decision to move a patient, survival goes down. We know that. But you can't stay at a scene for 2 hours. What if the patient has persistent VFib? Well, maybe part of this answer is double sequence defibrillation, right? Taking 2 machines and trying harder to shock them instead of just stopping at 360. Maybe the answer is 2 defibrillators, do double sequence defibrillation, and maybe that will get them out of VFib, right? And we see this over and over. The end-tidal CO2 is 40, but now we're moving the patient, and now the end-tidal CO2 goes to 20. And we were here for an hour trying to resuscitate the person, and we know moving them makes them worse, decreases the chance of survival. We know, and I said this before, one number you have to remember, for every 5 seconds you're off the chest this year, survival goes down by 7%. Do not, I always say, I'm the only guy of all these 20 people here, I'm the only person who can tell you to stop CPR, and I'm never going to tell you to stop CPR. I make it pretty clear. So this is why we have to continue compressions. And this is why moving somebody is almost a death sentence because your end-tidal CO2 changes. But again, you have to make a decision at some point to say, we've been here an hour. We have to get out of here. What are we going to be here for 2 more hours? So maybe end-tidal CO2 gives us a little help, right? Maybe it says to us, you know what, we've been here an hour. I know this is the patient in some sort of PEA, but the end-tidal CO2 is 4. We start out at 30. I feel very comfortable pronouncing this patient knowing 4 studies say if it's less than 10, nobody lives, right? Because that's the questions we're always asked ourselves. Should I have tried harder, right? But we don't have to ask those questions anymore if you do good numeric end-tidal CO2. The other thing that the studies show is if you have bystander CPR, you actually have greater chance in survival if you're bystander CPR. Another thing is if you have a shockable rhythm upon presentation to EMS. So when somebody calls me and says, we'd like to pronounce the patient, I go, okay, what's the end-tidal CO2? And they say 30. Okay, was there bystander CPR? Yes. Was the first rhythm shockable? Yes. I'm just saying, 9%. 9%, you've been there an hour, bring them in, right? And when I say bring them in, I don't know that I'm doing a good thing because I know I'm going to have ineffectual CPR during transport. Now, we'll talk about the Lucas devices and other automated devices in a minute, because maybe that will help us. Unfortunately, when the literature looked at this, the two trials, the paramedic trial and the Lynx trial, both showed that it didn't help with that decision, right? So this is a big issue for us. We're trying to figure out, but use that end-tidal CO2 to help you figure out who to pronounce patients. Very important. Less longboards. I hate longboards. I just was on a medical director panel in New Jersey. There were 8 of us, and I said, I believe longboards should be outlawed and nobody should ever use a longboard again. Do you know that the people around the country are not using longboards? There are places around the world that do not use longboards whatsoever. I believe, hopefully, all of you are under 30, right? I believe in your lifetime, you will have a day where there are no longboards to put people on. No longboards. The National Association of EMS Physicians and the American College of Surgeons Division of Trauma came up with a protocol that was very conservative in 2012 to use less longboards. What's that, like 3 years ago? So I go around to squads and I basically say, go to your local hospitals and tell them, I'm just going to follow the protocols, which is conservative, but tells us to use less longboards. Now, some places are saying, forget that. If you go to Houston, let's say we all leave tomorrow and go to Houston, no longboards. You don't even have the option of using longboards. ALS or BLS, they don't exist. Yale Basic Life Support did away with longboards. There are many people around the world which have done away with longboards. This is a good thing. Longboards are terrible devices. They were never meant to be used. They were never meant to be used as a splint. I used to work in one trauma center where every single time somebody came in on a longboard, we had to take the person off a longboard and hand it back to EMS before they left. Every single time. Now, part of the reason was because we didn't want to clean the longboard because that was expensive, so we would hand back a bloody longboard to EMS. But another reason was nobody needed it. What did we do with people who we thought had vertebral fractures? We took them off the longboard. What did we do with people who we were sure had vertebral fractures? We took them off the longboard. You get it? You know, use a scoop stretcher. If you want to use a longboard now to get somebody out of a vehicle, that's fine for extrication. But after that, take them off the longboard. You know, what do we do in the hospital if we think somebody has a vertebral fracture? We keep them lying flat till we get them into CAT scan. And what do we think if they don't? We sit them up at a couple of degrees, and we may keep the collar on. So whether or not you have a longboard and C collar are two totally different discussions. But longboards are going away. A.J. Heitman, the editor-in-chief of GEMS, was speaking at a conference, and he spoke before me, and he basically said it's his mission in the next 2 years to get totally rid of longboards from EMS. I don't know whether he'll be successful in that, but you know, for all of you who've been around a little while, remember we used to have these terrible things called shortboards, and we all used to use shortboards, and they all kind of went away, right? But what happened when we brought our first few patients into hospitals with no shortboards? They said, oh my gosh, what are you people doing? This is crazy, you're hurting the patient. And, you know, eventually they got it. So what happens in places where they get rid of longboards or use like criterias instead of just blindly putting people on? Well, the first few people say, this is crazy. And then next month, fewer people say it. And the month after that, fewer people say it. And then somehow the hospital director will send an email out to all the doctors. We're going to stop doing this. And half of them will stop reading, don't even read their emails. So the guy who's working at 3 in the morning will still say, what are you doing? And eventually, we will not have longboards anymore. These are not good devices. They don't help. We do more damage by longboards than they help. And why is this? Because people have more pain once they're put on longboards. And because patients have more pain, we do more CAT scans. Because trauma, right, in the hospital is not necessarily thinking man's game. If you have pain, we tend to image you. Right? And you have more pain by being on a longboard. And if you don't believe me, I mean, I remember my EMT class, we had to get put on a longboard and be driven around in an ambulance really fast. And they hurt like crazy. You actually get skin breakdown if people have poor protein levels, poor albumin, with a little bit of urine in the area. You can get skin breakdown in a matter of minutes. Minutes. So these are just terrible things, and we're getting away with them. Can you just start doing this tomorrow? Well, I tell people, you know, the way to create change is just to tell your local hospitals, you know, we're going to start following the protocol from 2012. Now, I'd like to say, just stop doing it tomorrow. but you have to follow politics. So I tell people to go ahead and bring the protocol to all their hospitals and say, we're just going to start following this protocol. And then in a few more months, the protocol will be more aggressive and more aggressive and more aggressive. Or you can just say, listen, Houston's not doing this. This city's not doing this. We should just stop doing it too. But this is just that we're in the process of change now. This is a really good thing for us, and we'll be getting rid of longboards eventually. And it will definitely be a fight, and then, but eventually we'll win. And here's the position statement, 2012, by the surgeons and the EMS physicians, and basically this was its very conservative first criteria of when not to use longboards. But again, other people just said, forget this, we're going to stop doing it altogether. TXA, if you've never heard of TXA, you should. TXA is the only drug we have in medicine that helps trauma patients. We just approved this in New Jersey for all of our paramedic units. We've been carrying on our physician vehicle for about 3 years. The military's been using this for about 12 years, and this is what they give to injured soldiers on the battlefield to stop their bleeding. There's only one drug that we're using widely like this. It's an antifibrinolytic. It works on plasminogen, and the way plasminogen binds to plasma, and basically on the lysine receptor, and basically this is an antifibrinolytic, so bleeding. And it's been shown in a few great trials that it has to be given quickly. So it should be given pre-hospitally. The best patients to give it on pre-hospitally are the ones who are entrapped, who are going to be delayed to the hospital. So I tell my docs, anytime you have a delay to a trauma center of 30 minutes or more, give TXA if patients fit criteria. The general criteria has been over the age of 16, so a trauma patient is over the age of 16 whose heart rate is greater than 110, whose systolic blood pressure is less than 90, who has some evidence of potentially needing blood, like blunt trauma to the chest, blunt trauma to the pelvis, or some bleeding vessel somewhere in the body, like an amputation that keeps on bleeding. So somebody bleeding. So normal saline or lactated ringers for bleeding patients is terrible. It doesn't work. We still believe in hypoperfusion, so we still believe in keeping blood pressures lower for trauma patients, not higher. Nobody bleeds normal saline. People bleed blood. They don't need normal saline. If your systolic's at least 90, and it's a very conservative number on my part, leave them alone. Don't give them fluids. You dilute out clotting factors. You have dilutional coagulopathies. This makes people worse. We did a whole big thing on the Twitter account about this. Or is it a Twitter account? Whatever it's called. TXA is the drug. It's a perfect pre-hospital drug. It's perfect. Why is it perfect? Because we only pay $450 for 10 vials. Temperature doesn't matter, right? The military uses in really hot temperatures and really cold temperatures. The motion of the ambulance doesn't matter because motion does not degrade it, right, that much. So it's a great drug for us, and we give it in the first 1,000 milligrams of the first dose can be given roughly over 20 minutes. We give it a little bit quicker, but that's okay. And you're going to ask me, well, if you're giving a drug because somebody's bleeding, isn't there a risk of clotting? Right? Because we all know a big problem with these trauma patients is we put them in the hospital and they had clots in their legs, clots in their lungs. And the big study that looked at this, the CRASH 2 study, said no increase in clotting. This drug saves lives, TXA, tranexamic acid, really, really important. And we'll give it, there was just a study released last week in pediatrics where the average age was 11, and it did really great for kids who were under 18. So you can probably give it at any age. We're going to start in New Jersey at 16. We don't move as one unit in New Jersey, so basically we approve it, and then individual systems can decide what they want to do and give it or not give it. We're certainly going to give it because this drug is saving lives. We currently, 2 weeks ago, the article was in Annals of Surgery. This week it was in Journal of Acute Care Trauma. We currently have no bad studies on TXA. But if tomorrow a bad study comes out on TXA, I don't care. Because I have 8 studies that say it's fantastic, decreases mortality, decreases transfusion, and saves lives. And I'm not going to freak out over one bad study. Because that's a question people always ask.
Can you just repeat the name, the full name?
I knew you'd ask me to spell this. But if you just Google TXA for anything, it'll come up. But, yeah. There's always somebody who wants me to spell. Here we go. TRANEXAMIC. And the big study was called the CRASH-2 study, CRASH-2. But now we have the PEDTRAC study, and we have, you know, the other big contraindication to this that people always worried about was you actually showed worsening mortality in people with isolated intracranial bleeding. But now there's been a few studies that look at people with isolated intracranial bleeding, and that's actually totally fine as well. So many systems around the world are using TXA like water, It sounds like a perfect drug. But when that bad study comes out, which it will eventually, I'm not going to freak out because I have overwhelmingly positive literature about this.
Can I ask a question?
Yep.
Just to go back on the defibrillation, if it's practicality, we're not going to have 2 defibrillators. Would they be able to change that the maximum, instead of being 360, would be 720? Would that have the same effect?
But if I wanted them to change things, I would prioritize. And the first thing I would have them change is I would have them do see-through CPR for life packs, because I know that I can't be off the chest. So that would be the second thing I would ask for.
But either way, you don't have 2 defibrillators.
Right. Right. I mean, you could argue both ways, because if I ask them to make it 720, they might say to me, do you have good outcomes data? And I would say I don't. So
then out of all these literature and everything else, we don't really have any scientific proof to back it, because it would be over time.
We have scientific proof for return of spontaneous circulation. We have scientific proof for improving end-tidal CO2 for double sequence. We don't have any outcomes data, but we don't have any against us either. So what I'm saying now is I'm paying really close attention to this literature, and I'm going to start doing it, especially after 2 shocks don't help convert my patient who's in VFib. And after 2, I'll do it for the 3rd. And am I doing that based upon any science? No.
Right.
No. But again, my science is improved ROSC. And to me, if you get ROSC, something's going well, right? It doesn't mean you're going to walk out of the hospital alive, but something about that heart is right. So maybe if we start doing everything else really well, maybe then this will change it. But anytime you're trying to change an outcome in a cardiac arrest patient, you're asking a lot of that one outcome. So.
But in any patient that you have, we have a board, we have a REMAC committee.
Sure.
They're the ones that come up with protocols.
Sure.
So to say everything that we've done up until now is wrong, this is my theory, or this is what the backing or the literature shows, then there has to be a reason why you have this group of people that every 5 years, and for a while it was every 2 years, every year, was changing the protocol. The spinal injury was something which the longboard issue has been around, you know, whether to do less of it. But still, all these changes, it's difficult to get this REMAC committee to change.
Sure, like anything, like us in New Jersey too, it's always difficult. All right, external blood loss. So we came up with something called the MAR method. So if somebody has a motor vehicle collision and they're bleeding, we came out with a formula to actually figure out how much blood loss there is at the scene. So somebody's in a bad car accident, there's blood on the ground. Haven't you ever said to yourself, how much blood is on the ground? So we came up with a formula called the MAR method, and basically we figured there was a mathematical formula, and basically we figured that your fist, no matter how big or small your fist is equal to about 20 milliliters. Take your fist and see how many fists you have over that non-absorbable area like concrete. Multiply that by 20, and that's how much blood loss there is. We improved precision and accuracy for determining blood loss by 153%. So this is the only method in the literature. Will this be in the EMT and paramedic books? Absolutely, they've already asked us for it. For the paper, how long will it take? 3 to 10 years, like anything else. So one fist is roughly about 20 milliliters, because we knew that we had to figure out something quick during a crazy car accident or car collision for somebody to figure this out quickly. So one fist is about 20 milliliters, it has to be a non-absorbable surface, count the number of fists, multiply that by 20, and that's how many that's how much blood loss there is. Better use of cervical collars. Cervical collars still scare me. There's great studies to actually say a perfectly placed cervical collar can disrupt odontoid fractures and still be problematic. We have nothing better in the literature right now to do than place cervical collars, but there's still evidence that maybe this isn't the best thing for immobilizing necks. But because we have nothing better to offer right now, we're sticking with cervical collars. The airway's not the priority. do you know that most people around the country, and you may know this, do not prioritize the airways? It's not airway breathing circulation, right? It's circulation, airway breathing. Circulation is much more important. This is why people around the world are teaching do compressions, do compressions. We have a group in New Jersey who's actually going into malls now and saying to people, don't even ventilate, don't bother. Somebody goes down, they have no pulse, just do compressions. Don't ventilate, don't ventilate. The first study came out in 1994 which said ventilation is really not needed. Just do good CPR. And that actually had the same outcome than if you ventilate. We've been teaching BLS squads for a while now, asynchronous ventilation, meaning do not stop CPR to get that air in, and if the air doesn't go in, it's totally okay. But stopping CPR is a big problem. If you look around the country, there are still systems where if the paramedics go ahead and they intubate too quickly, that's associated with worsening outcome. The best data says if you don't intubate for the first 6 minutes, these are the rock collecting data systems around the world, if you intubate within the first 6 minutes, you have worsening outcome. So most systems, so I was just in Dallas with one of my old fellows, now the assistant director of the EMS system there. If the EMS system intubates within the first 6 minutes, they get dinged. Can you imagine that? The goal is not to intubate, to put an LMA in or to put a king tube in and to get out of there. Now, why is that? Well, I think the best answer is we don't know. The second best answer is I think it's because when people are intubating, everybody pays attention to the guy intubating, and they stop doing effective CPR. So if you can continue doing effective CPR and not interrupting your CPR, then I think it's totally okay to intubate people pre-hospitally. But I think in systems where that can't be done, then you don't intubate, you put a supraglottic airway in, and you just do compressions, and you go to the hospital. Right? So that's the focus, to do constant compressions and not pay attention to the airway. And this is one of the studies, the famous Japanese trial, this is from February 2013, where there were worse outcomes in people who got intubated. Worst outcomes, one of the biggest trials ever in all of medicine.
6 minutes from your arrival on scene or 6 minutes from downtime?
6 minutes from your arrival on scene. So I'll talk about this. This is the non-rebreather. The actually AVOID trial, this is really important. The AVOID trial came out in the last 2 weeks ago, and it actually showed that people who are having STEMIs, heart attacks, do worse when they get oxygen. If your oxygen saturation is at least 90%, right, so you're not hypoxic, you do better with STEMIs if you do not get oxygen. So this is what all of the literature people are talking about. We've known this in kids and neonates for years because of free radicals, and people have been waiting for this AVOID trial for years. If you just type into anything, the AVOID trial, you'll see people online talking about this. This is really kind of exciting things to say how people with STEMIs should not get oxygen unless they're hypoxic. And that's probably true, by the way, now for almost everything. Difficult airways, my favorite drug for RSI.
What do they do with the ERs now? The person coming to the center, they don't, no nasal cannula, no nothing?
No, what do they do in the ERs?
Depends on the attendant.
Yeah, you know, you guys are usually more up to date in the literature than many ERs. So it depends upon the hospital.
Where's your ER?
So my ER, well, my ER has me yelling at them all the time. So, I mean, in a nice, warm and fuzzy way. But we mandate they do nasal cannulas. That's not even an option. We let them touch the airway early, but the ER is not a real environment because you have 10 people at the code, you know, so you can intubate quickly because you have multiple people doing CPR without interruptions. My ER doesn't have Lucas II devices. After the paramedic and links trial, I'm hard pressed to buy them. But you know, the best study in CPR shows that if you have 3 individuals each doing CPR for 2 to 3 minutes and they continuously rotate, that's more effective than one person going more than 3 minutes. And that's, you know, that's science. So when that person says, I'm okay, I can go for 20 minutes, you are not okay. I don't care how good your CPR looks, you are not okay if you're going more than 3 minutes. You just need to go into the cycle of rotation.
So it doesn't make sense.
What?
It doesn't make sense that the thumper it can do better. You can't. If I told you that I know a guy named Mark Merlin or Ellie Rowe who could do CPR for an hour straight, and they measure, and he could an hour straight. I'll tell you, he can do it. Would you tell me we shouldn't use him?
The second one for sure.
So, I mean, I bet this is a guy with really big biceps and triceps and deltoids, right?
Yeah, but you can do it. The thumper can go for 45 minutes before you switch the back.
Right, so that's what I like about these devices. So even though the literature is not supportive of it because the paramedics and Link trial poo-pooed these devices, I still like them. I still think they're great devices. I just wish there was more support, and you know this, I just wish there was more support in the literature for them. But I believe that, we're moving people. We're with people for a long time, and we don't have 20 people who can do CPR. So that's why I think they're okay. I just wish there was one good paper. I mean, the Cochrane database reviewed this and says we don't have any good support for this. But I still like them. I just realize the literature is not on my side, and it's a fair argument when somebody says we want to buy 10 of them, but we don't have that much money. It's a fair argument to say maybe we need to focus our money somewhere else, particularly if we're an EMS system which gets to the hospital pretty quickly. If you're in the middle of nowhere and you have 2 EMS providers, get a thumper. It makes perfect sense to me.
Do you think it makes a difference about what the response time is for BLS?
I do.
To get there, because I think here,
I do.
I think Hatzolah Queens has 10 thumpers or something like that.
Every truck
Every truck has one.
Yeah.
The reality is our response time is 2 to 3 minutes.
Is the literature say it's worse or no better?
No, it's no better.
Yeah, it says no better. The paramedic, you just have to Google the paramedic trial. And the Lynx trial actually looked for people who were doing lots of hands-off CPR, and it still wasn't any better. So,
Stapleton and Mark Henry from Stony Brook increased cerebral perfusion.
right. Right. So this is why I'm not willing to give up on it. But I do acknowledge the literature is not overwhelmingly supportive of them. But I still like them. And I still want people who can afford them to get them. But again, when somebody says we can either do this or we can do that, I say, I got to go with the science. All right.
We love it. We're practical. We love it.
Yes, I love it too. All right, intubation, RSI. My favorite drug overwhelmingly in literature is ketamine. Ketamine. I think it's a superior agent. My next favorite agent is etomidate. We're big believers in paralytics. 12 studies in literature to say if you paralyze somebody who you're going to intubate, you're better first pass intubation. So I'm a believer that rocuronium is the best paralytic in the pre-hospital setting with succinylcholine #2, and ketamine is the best induction agent. In my system, I chose, and I could do whatever I wanted. So we give rock if it's available. It's often not available. So we give succin ketamine, and then after intubation, we give another dose of ketamine and fentanyl. And fentanyl should be thought of as a primary agent post-intubation because people need pain covered first and sedation covered second. Fentanyl is an amazing agent if you're doing like IHOPs or critical care transports. Fentanyl drips for intubated patients. We rebolus fentanyl repeatedly. Fentanyl is a great drug. Ketamine is such an important drug because ketamine is a sympathomimetic drug, works on the NMDA receptor. Ketamine basically is good if your blood pressure is low. It helps bring up your blood pressure. Etomidate lowers your blood pressure. What about succinylcholine? Succinylcholine, you actually need a higher dose of sux if you're hypotensive, right? It's broken down the periphery. So if somebody's hypotensive, they need more succinylcholine, not less succinylcholine. Same thing with rocuronium. They need higher doses. If we're going to give succinylcholine to somebody hypotensive, I make it 2 per kilo. If we're going to give rocuronium to somebody hypotensive, I make it 1.6 per kilo. Bigger doses broken down the periphery. Your cardiac output is inversely proportional to the amount of paralytics you give somebody. Ketamine is good. What we're starting to do now, and this is being done around the country, people are talking about this. I guess it's not actually being done well, but people are talking about it, is push dose pressors pre-hospitally. Anesthesia's been doing this for 30 years. We're finally catching up with what anesthesia's been doing it. I have something on front of the console for we have 100 docs who answer the console, so it hits them in the face every time they pick up the phone, which is if your systolic is 90 or less, while during the peri-intubation period, you're giving 10 mic bolus of epinephrine and repeating it every single minute till the systolic gets to be above 90. The first thing that happens when you intubate is, whether you paralyze or not, is the patient gets hypotensive. You're taking somebody from a negative intrathoracic pressure to a positive intrathoracic pressure state. You're augmenting preload, you're reducing it. Whenever you intubate, the first thing that happens, whether the monitor says this or not, is the patient has a reduction in preload. They get hypotensive. Sometimes that may not be right away. Sometimes it may be in a few minutes. But the one thing we learned from the literature this year more than ever before is any hypotension during the peri-intubation period increases your mortality by 50%. Any hypotension during the peri-intubation period, this was shown this year to be true for kids, not just adults, increases mortality by 50%. A hypotensive patient who gets intubated, who may totally need it, the mortality increases. So we're getting blood pressures up high, so when we intubate, right, and the blood pressure drops, the patient will be okay. Because the most dangerous time is that peri-intubation period, either while you're intubating or right before, when that blood pressure is going to go down. Get the blood pressure up. We're pushing 10. 10's a very low number, by the way, but it's where we're starting. And then I'll keep going, getting more and more and more aggressive. So we push 10, 10, 10 every minute till we get the systolic above 90. And I'll tell people, like, I'm happier with like 120, bigger numbers, because I know it's going to fall down again. I know it's going to fall down, and we're increasing mortality. So this is why, more than ever, push-dose pressors seem to be the way to go. Around the country, people are finally starting to really talk about this. This is why ketamine is such a wonderful agent, because it's a sympathomimetic. It helps the blood pressure. Etomidate is very bad in hypotension. First of all, it's terrible in sepsis. It's terrible in hypotension, right? And it also doesn't work very well. And Versed is a terrible drug, because Versed, if you give Versed with succinylcholine at the same time, Versed actually takes up to 90 seconds to start working in hypotension. That means your succinylcholine is kicking in before your Versed is, and the patient's paralyzed but not sedated. So that's why it's not. That's why Versed is a terrible drug. Plus, Versed makes you more hypotensive.
We don't, part of the rest of the protocols, we have fentanyl, we have Versed, you're not ketamine. We don't have that.
Right. So I love. So
I was at a lecture yesterday that the doctor swears that within the next 5 years we'll have ketamine.
Fantastic.
Well, it should have been today.
So, of all the drugs you mentioned, fentanyl was the one I love the most, because fentanyl, for the most part, is neutral on blood pressure. Right? It also blunts the adrenergic response. That's why a lot of people like to give it pre-intubation. Etomidate's okay, but in hypotension or sepsis, it's not good, right? So, and people will yell that, well, we don't have good outcomes data with etomidate. Well, we know etomidate causes adrenal insufficiency. We know etomidate causes clinically significant hypotension. We just don't know that one's causing the other. To me, I don't need more studies to prove it, because I know clinically significant hypotension in the peri-intubation period increases mortality by 50%. That's why I don't want to do it, right? But fentanyl is just a great choice. I mean, I tell people, change the way they're thinking about the intubated patient. Think of pain first and sedation second. Right? It hurts to have an endotracheal tube in your throat. Think of pain first and sedation second. Ketamine is also good for a million things. If you look at the psychiatric literature, the literature's exploded in the last month with ketamine for bipolar disease, intranasal ketamine for all sorts of things. Ketamine drips on patients. Ketamine for violent patients. Ketamine for excited delirium, right? So when we have people who are fighting, right, the problem is the Versed, it just takes a little bit too long to work. We'll just go bam in their thigh with ketamine, and in a couple of seconds, they're like nice people, right? And the other thing that's nice is your airway reflexes stay protected. Your airway reflexes stay protected. Ketamine, by the way, is the first drug we reach for when we're going to do a pre-hospital amputation, right? Because people will sit up, their airway's totally protected, and they watch their arm being cut off, and their airways totally intact. That's why and it keeps your blood pressure up and improves your blood pressure. That's why it's really important.
Can you explain just how to do a push-dose epi?
So push-dose epis, we take the cardiac epi, which is 1 to 10,000. We take 1 milliliter out of that. We mix with 9 mLs of normal saline, just from a bag, and then we just push 1 ml at a time. That's 10 mics, right? Make sense? And then we're just pushing 10 mics every minute till we get the systolic above 90. Right, because if the patient's blood pressure is 70 and you're intubating, that's deadly, right? I'm not saying it may not be totally reasonable to do it if the patient needs it. I'm just saying expect the patient to get more hypotensive. Expect, there's a risk of the patient going into cardiac arrest. And these are the cardiac arrests we can prevent. So somebody called me a couple of days ago. They couldn't get a hold of the command doc of the console. They called me on my cell phone. It was like 6 in the morning. And the woman gets on the phone and says, hey, I have a really critical patient. I said, Mom? And he said, no, this is the paramedic unit 203, and we have a critical patient, and we can't get a hold of the doctor. I said, and I tell the paramedics all the time, call me anytime you have a sick patient. So they had somebody in PEA. I hate the term PEA. Throw PEA away. The literature says stop using the term PEA. So I said, first thing I say is, well, what's on the monitor? And they said PEA. I said, no, what's on the monitor? And the person said PEA. So PEA in the best literature now is divided between two things, mechanical and metabolic. Your complex is wide, think of metabolic like hyperkalemia. Your complex is narrow, think of mechanical. And the big reason you have mechanical PEAs is right ventricular disease. This person said this patient's coded 10 times. The blood pressure is 60 right now, and they keep going in and out of cardiac arrest. So I said, what did I say? I said, she said one time they were having an MI. I said, let me guess, probably inferior wall. She said, how'd you know? Well, if most of the mechanical problems are right ventricular, the only type of STEMI that goes to the RV routinely is inferior wall, right? So it was inferior wall MI. She said, I like to give calcium. I said, brilliant. Actually, it wasn't all that smart because the patient had narrow complex PEA. But, I'm like, well, this patient's really sick. To throw 1,000 milligrams of calcium at somebody who's really sick is perfectly reasonable. You're not going to hurt anybody. And I said, this is what I want you to do. I want you to stop CPR. She said, the patient's in cardiac arrest. I go, yeah, it's okay. And I said, stop CPR, and I want you to start pushing epi. And I want you to start pushing boluses of epi. And she started doing that, and the patient came out of cardiac arrest and never went back in. Because all that was happening was like a pseudo-EMD. The patient was too hypotensive for them to feel a pulse, but they had a narrow complex on the monitor, right? If this person was in an ICU with an arterial line, it just would have been hypotension. We would have been getting fluids and pressures. But because the patient was pre-hospitally, all we had was somebody who we were calling PEA. So all we did was, and she was giving fluids at the same time, we pushed those pressures and fluids, but fluids just weren't enough because they kept going in and out of cardiac arrest. So we started giving epiboluses. They never went back, and I called the ER later in the ICU, they never went back into cardiac arrest for the next 24 hours. So you got the blood pressure up. That was really what the patient needed. All right, lidocaine and defisculating doses. Defisculating doses of paralytics were totally made up. Right? No science behind it. The study came out in 2001 by this person named Clancy, which said nobody who gets RSI should get a defisculating dose. Lidocaine, I think the literature is pretty equivocal. I don't let our medics do it. We took it away. I think there's some science for it, some science against it. Some of it is because of airway suctioning, but it's not great science. I think when a person is decompensating and you have 10 things to do, I wouldn't reach for lidocaine first. But if somebody wants to give lidocaine, I have no big problem with that. But defisculating doses really don't make sense. Tourniquet strokes, let me get into some hot topics. Diuretics, Lasix for CHF. What a mess this is. We wrote a 4-page clinical pearl about this. You guys want to know about Lasix and CHF? Jeez, what a disaster this is. So, all right. So we used to all give lots of Lasix. Then we all stopped giving lots of Lasix. Then we started giving it again. Then we stopped giving it again. Certainly we've known for years that Lasix has some bad consequences. One is it increases systemic vascular resistance and it decreases cardiac output. So basically people who are in acute decompensated heart failure have really high systemic vascular resistance to start with. So this makes it worse. We used to think that Lasix activated something called the neurohormonal system, which basically caused people to go into renal failure and make them worse, right? Because their kidneys would shut down. The big trial came out, it was like 2012, I think, called the DOSE trial. If you want to read something good on Lasix, the only prospective trial ever written about Lasix for CHF, is called the DOSE trial. D-O-S-E, the DOSE trial. The DOSE trial compared high-dose Lasix with low-dose Lasix in acute decompensated heart failure and found people who got high-dose Lasix actually did better. But we were all afraid that we were causing renal failure. Now, they took out patients who had cardiorenal syndrome, so bad hearts and bad kidneys. So indeed, if you give Lasix to people who have bad hearts and bad kidneys, you could throw some on dialysis and make some people worse. Lasix also doesn't work extremely fast. So unless you're with the patients for a good hour or two, the big effects of Lasix probably are helping very, very little. Plus, not everybody in acute decompensated heart failure is truly volume overloaded, right? Some people are not. The kidneys see heart failure as a volume depleted state because your cardiac output's diminishing. You're not getting enough blood flow to the kidneys, right? So if you give those people who have blood pressure of 70 or bad hearts and bad kidneys, and you give them Lasix, you're probably going to throw some people onto dialysis. That's the issue with it. And nitrates are really good because most people who are really in acute decompensated heart failure, especially the ones volume overloaded, actually need nitroglycerin, 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 nitroglycerin. So I believe that if you're going to give Lasix because somebody's really volume overloaded, then it should be a higher dose. We usually give 80. If you're not going to give Lasix because you don't believe that this acute decompensated heart failure is being caused by a volume overloaded state, then it's okay not to give any. And in fact, if you get them getting to the hospital soon, there's probably no big reason to give Lasix that quickly at all. And some literature now is saying that this is really just fluid shifting that's causing the acute decompensated heart failure. And some people are really ischemic, and it's getting more complicated than ever. But I think the literature is telling us that we're probably not hurting too many people by giving Lasix. People who are really volume overloaded are being helped by Lasix. And you know this, you've gone to some people's homes, they have acute decompensated heart failure, and you check their ankles and there's no edema, right? And you check their pretibular area and there's no edema. And you go, maybe this is being caused by fluid shift, or maybe this is being caused by ischemia. And those people probably need no Lasix, and that's kind of the best evidence we have. And then there are people who are really volume overloaded who are in heart failure. And those people really do need to be diuresed. And then I think we also have to remember this is really hard to figure out because the studies in the ER show that we get acute decompensated heart failure versus versus multilobar pneumonia wrong about 10 to 20% of the time. But we have X-rays and calmness, and we can check sacral areas for edema. And we get it wrong 10 to 20% of the time. And we have BNPs and all this information, and we keep messing up. So to figure some of this stuff out pre-hospitally is not very easy. And so if you're going to be at the hospital soon, why give a diuretic? Because the people with multilobar pneumonia will have transient bumps in their renal function. We know it's not hurting them, but they will have transient bumps in their renal function, and it will make them worse transiently.
What about nitrates? I read something about nitrates. You said we're not giving enough nitrates in CHF.
Yeah, because nitrates...
It's our protocol that we don't give Lasix and we just keep giving nitrate.
Yeah.
You said people typically are not giving enough.
Right. So I don't think Lasix is bad. I just think it's just become complicated.
Nitrates.
Right. So the nitrates are great. I mean, nitrates, are great. When somebody presents to me with super high blood pressures in CHF, I'm the happiest guy on the block, right? Because I have a lot of room where I can make them better. And I can do this by giving lots and lots of sublingual nitros. And if you live in a world where you have nitrous spray, lots of nitrous spray as well. And I can give them double doses until I really get their blood pressure down. Many EMS systems around the country are giving push-dose IV nitroglycerin.
What do you want to bring it down to?
So I want to bring it down enough so their symptomatology improves. So whatever that is, I'm okay with that. Usually when they get to be 90, then I start saying, let's slow down. But we're giving big doses of nitroglycerin. Big doses of nitroglycerin. So that means we're starting usually, if we're giving an IV, we're starting 50 mics per minute, and we'll titrate up to 150.
We're going to push the trial. We're 0.4.
No reason why you can't?
No reason why you can't? Protocol is the reason why.
Well, so I'm talking about medically.
Our doses are 0.4. Each channel is 0.4.
Yeah, so 0.4. I usually give an order for the paramedics to double it to 0.8, and I'll tell them to give it every 3 minutes.
Every 3 minutes.
It's like paratrodon.
Remember, it's about 400 mics. Think of it this way. If we're giving 400 mics sublingual, that bypasses first-pass metabolism in the liver. That's getting right into the blood. That's better even than giving IV nitroglycerin, which takes a long time to go through the tube. Right? So the mistake people make in the ER all the time is they start their nitroglycerin IV too low, but all the nitro the paramedics have given pre-hospitally is much higher. So you're actually going backwards when you get to the hospital sometimes.
Right.
Yes.
Because they're afraid, though.
Yes, they're afraid.
What happens is that on a typical call, you'll say, come into the hospital, say, they only give 3 nitros. In theory, you're really doing it like clockwork every 5 minutes. It probably should be closer to 4 or 5 nitros.
And I've had paramedics say, oh, I got in trouble because I gave 15. Well, you're with a patient for a few minutes. It's totally okay. You did a good thing.
And their blood pressure held up 15
So you
nitros?
moved to New York when?
You guys have terrible traffic.
One of the challenges we've been seeing practically when we review the PCRs is that once the CPAP masks go on, they don't give the nitro anymore. Struggle so hard to get that CPAP.
This is why, you're totally right. I mean, two thoughts. One is, this is why we approved IV nitroglycerin in New Jersey, because we kept, because now we have a way to give IV nitroglycerin. So, right, that's certainly a problem. And CPAP is this amazing thing. I mean, CPAP we used to think of last line. CPAP now is a first line treatment. That's why CPAP's utility for acute decompensated heart failure is #1, because even if you're wrong and it's not heart failure, you're going to be right, and it's going to help most everybody. Even if they
These are just making them more comfortable.
Well, it's not helping. I mean, if you CHF, it's not helping the chronic process, but it's helping the acute exacerbation. In fact, some studies where they've been really pure and they've given nothing but CPAP, by the way, they've still made people better.
But if given the choice with sublingual, you'd rather go nitro over CPAP.
What can you do both?
Because once you get that mask
Once you get the mask on, you can't get it on.
you can't get it on and off.
Yeah, it's not easy. Yeah, it's not easy.
What would you choose?
I hate those choices.
Take the chicken.
If somebody's really decompensated, my concern is if I keep giving sublingual nitro, what do if you're a non-rebreather, I don't know, what a hard question.
What's your thought on pace?
I hate NitroPace. NitroPace is a terrible drug. NitroPace takes 30 to 45 minutes to appropriately work. If you're with a patient an hour, I guess you could do it. Its absorption is incredibly, incredibly erratic. So some people it gets absorbed quickly, some people it doesn't get absorbed for long periods of time. It gets on your finger. When I was a paramedic, the only reason we gave NitroPace was for people who have bad veins. We put nitro over their veins, they would pop up.
Was after you gave a first few nitros, then you follow with the pace so that it continues.
Stop doing it.
We don't do it anymore.
Yeah, it's too erratically absorbed. The only thing is we frequently have problems with ordering IV nitroglycerin. So when we put the CPAP machine on, then we'll put NitroPace on their chest sometimes so they can still get some nitroglycerin. Although I think that's not good. At least maybe they're getting some, but it's so erratically absorbed. But the question is, why not? All right.
Might as well go safari.
You don't really need D50, right? That's a myth. The literature is pretty consistent that D25 is totally okay. Actually, D50 prolongs hospitalization. There's a trial called the MOORE trial, M-O-O-R-E, and D50 actually increased the number of days in the hospital, made blood sugars hard to control over the next 3 days for the patients. What?
Cardiac arrest. Not cardiac arrest, hypoglycemia.
And hypoglycemia. Is naloxone good? I'm going to start asking you guys questions. Is naloxone good in cardiac arrest? Right. So there's 3 answers. I don't know the literature, so I can't give you a good answer.
That's the right answer.
So the answer is there's one paper in the literature. I wrote it. It was in resuscitation.
That's the right one.
Thank you.
The Morrison paper.
And we looked at this, and we looked at nitroglycerin. Oh, I'm nitroglycerin. Okay. Next I'll say Lasix. We looked at naloxone in cardiac arrest with people with suspected opiate overdoses, and found 20% had an improving cardiac rhythm, meaning they went from asystole to VFib or VFib to sinus rhythm 20%. So naloxone is probably okay in cardiac arrest. Is it really making more people walk out of the hospital alive? Probably not. But it is just kind of interesting. So if I have somebody with a suspected opiate overdose, I will certainly give them naloxone. I don't know that it's helping, but I think it's helping a very small percentage of people, and why not do it? What's the right dose in cardiac arrest? Well, we're the only study in the literature, and we gave 2 milligrams. Why? We totally made it up, right? Like most things. Is intranasal naloxone good? Yeah, intranasal drugs are fantastic. Right? It bypasses first-pass metabolism. What percent of naloxone gets absorbed through the nose? It's about 4%, so like not a lot. That's only based upon one study. And so 4% gets absorbed through the nose. I'd rather paramedics give that as a first choice, right, rather than take out an IV and give it and wake some people up pretty quickly. Can you You know, so in New Jersey, everybody has naloxone now. The police have it, everybody has it. And that's probably totally okay. You know, there's a whole movement now for physicians, for people who are heroin addicts, just to give them prescriptions for naloxone around the world. And like give it to their families, just like they give them like glucagon pens, and just give this to them and they can use the naloxone. So I'm actually a supporter of that. Intranasal fentanyl is fantastic for people. Intranasal Versed is fantastic for kids with seizures. And intranasal glucagon probably has a very rare indication. But it's okay. You guys know this if you're from New York, ALS for trauma. Did you read the recent article by, I forget her name, the PhD student from Harvard about ALS versus BLS? You did? One? Yeah. So no, yeah. That's a 2-hour discussion. Tasers. So what does taser stand for? For $100, what does taser stand for? Taser stands for Thomas A. Swift Electronic Rifle. This is really New Jersey. Recently became, I'm a big fan of tasers rather than lethal force. I can tell you that there was a big study in literature about 2 years ago where they took people, biggest cohort ever, and they took people who got tased by the cops. But they didn't just take young, healthy people. They took people who were old with pacemakers and cardiac problems and AFib, and they said, what's the real outcome? Not in the healthy people, but in everybody. And even in people who have heart problems, cardiac arrhythmias, they all did fantastic. So the likelihood of having a bad outcome from somebody tased is extremely, extremely rare.
Dr. Merlin, you used that part before, said no ALS for trauma. What's the reason?
Because I like people about the way New York does things, and when you tell certain people around the country that there are actually people that don't routinely call ALS for trauma, they freak out and they scream and they go running out of the room.
There's not much that we do.
No, we don't want to.
Right.
Because it would probably delay transport once they stop.
Right. That delays transport and longboards delay transport. Much less lights and siren. You know this. I wrote 2 papers on lights and siren. The utility of lights and siren from somebody's house to the hospital for non-critical patients is almost nothing.
You're in the right neighborhood for that.
Traffic is another story. But even still, here IV low pressure. IV low pressure is not a good drug for people who have STEMIs. We learned this way back in 2005. Oxygen for STEMIs is bad. We talked about this.
What was that helicopter?
So pre-hospital hypothermia. Pre-hospital hypothermia has now been approved by almost every major society now, that there is no clearly benefit to people who have ROS pre-hospitally and making them cold. That's almost every society now, every published paper. Even in the hospital, there's some controversy now because of a recent paper that came out.
So that's out the window now?
So what happened to all the...
Oh, look, here's the Super Bowl. This is one of my old docs and me. That's my son. He hasn't seen me too much, so I took him to MetLife and let him throw around, that's somebody's locker. I don't know who it is. Oh, those are 4 Super Bowl trophies. I wanted to get to... Oh, I just got to do this really, really quick because I'm so tired of talking about Ebola. I'm going to do Ebola in 30 seconds or less because I just like talking about science, not made-up stuff. Where fear and superstition overtake science and common sense. Good literature. So here's the only good literature I think there is, because there are no Ebola experts, right? Maybe the people who are treating the disease in West Africa are the experts, but certainly not most of us who don't live there or don't treat these people on a regular basis. But everybody's become an expert on this disease. And New England Journal of Medicine has published a couple of great papers on it by a lot of these people who do deal with this on a regular basis. So I would say the only evidence really is the study that New England Journal of Medicine published on the first 4,507 cases, the first 9 months experience since this quote-unquote pandemic, which is not a pandemic at all, came out with Ebola. So the recent surge. And here are the diseases that I worry about, me personally. Heart disease, cancer, COPD. You know what number Ebola is? 8,006. I don't have time to worry about 8,006. I got too much going on, right? Just getting through the Lincoln Tunnel is more concerning to me than 8,006. So here's the Ebola mortality. Forget about what anybody tells you. This is the science based upon the first 4,507 cases. The mortality in all comers was 70%. And this is in West Africa, right? Not in the United States. Hospitalized mortality was 65%. Healthcare worker mortality in the middle of West Africa with poor resources is 56%. That means that 44% of healthcare workers in West Africa, right, will do absolutely fine. A friend of mine after this lecture came up to me and said, I have a friend who is a doctor who died from treating Ebola patients. I said, I'm just curious, what kind of universal precautions? He said, nothing. I said, did the guy have gloves? No gloves. And he treated people for years with Ebola. So Ebola mortality in the U.S. from contracted diseases in the United States is 0%. I can't worry about 8,006. I just don't have time. So here, I'm almost done. Ebola signs and symptoms. These are the first 4,507 patients. Fever was 87%, which means 13% of patients who have Ebola will have no fever. It's not a good screening tool. And by the way, bleeding, because we talk about this being a hemorrhagic fever, only less than 5% had uncontrolled bleeding and DIC. You know, here's the R0. The R0 you should know about. That's the transmissibility of the disease. The measles is about 17 to 19. For every one person who gets the measles, 17 to 19 will contract it from that one person. Ebola is about 1.7 to 2. The Sierra Leone Ebola is a little bit higher than that. And how do you get it? You get it by diarrhea, by coming into contact with vomiting or feces or diarrhea. The outbreaks, the incubation period is 11.4 days. There have been 27 outbreaks in the history of the world with Ebola. 0 pandemics. Ebola has been here before. Read the book, The Hot Zone, right? Which wasn't a perfect evidence-based, a book that talked about this. Ebola was here in 1989. It was 10 miles from the White House. 100 monkeys got Ebola. About 29 of them died right away. What happened to all the people who treated these monkeys with Ebola in Reston, Virginia? All of these people with no universal precautions, how many humans got Ebola? 0. 0. And the Hot Zone basically said Ebola's coming back, we know it. And I would say just don't go crazy and use the same universal precautions that you use with everybody else who has diarrhea, et cetera, et cetera. It is not aerosolized, even though if you read Wikipedia, you'll freak out a little bit because they'll talk about how to aerosolize Ebola. You can aerosolize lots of viruses in the lab. Doesn't mean you can transmit it in aerosolized fashion, right? Here's Doctors Without Borders, maybe one of the only groups who've been treating Ebola for a long time. And here's what they say. Ebola is a hard disease to catch. No isolation is needed of patient without symptoms. The only experts we have. So why are you afraid? Don't be afraid. Here, all right, this is what I'll end with. Here, I'll change doctor to bad. I just gave this lecture to...
More Americans have been married to Kim Kardashian.
She's a pop person? All right. The good doctor versus bad doctor, you can change this to paramedics. All right. Ketamine, good. All right. Hands-on defibrillation, good. PEEP valves on BVM, good. No PEEP valves, bad. Stop doing compressions, bad. Nasal cannula greater than 15, good. No oxygen, bad. Fentanyl, good. Morphine, bad. Now, morphine is getting a bad rap. There's actually much more studies on chest pain with morphine than there is fentanyl. Morphine causes a histamine reaction, so you have side effects like itching and stuff. When you take lots of narcotics, you get that side effect. So I don't think it's a terrible drug. I just think fentanyl has a lot better reasons for us to start giving it much more routinely. You know, fentanyl is very short-acting. There's a whole bunch of people around the country writing papers about giving fentanyl and morphine together. Fentanyl will start working quicker, and morphine will last longer. So that's why they're suggesting giving both together. You know, so, but, I mean, you have an hour. Who asked the question? You know, it's not an easy question to answer, but once you give it in about 20 minutes is when people may need more. Continuous compressions, ultrasound, chest x-rays are slowly going away, ultrasound is slowly coming back, interrupted compressions is bad, continuous compressions is good. All right, so if you're talking about ketamine, it's great. The big bad thing people are going to tell you for the rest of your life is ketamine is bad for people with head trauma because it increases your intracranial pressure. Last month, the article came out that's totally wrong. We've been wrong for many, many years about this. This is a great drug, even in head trauma. All right, questions. It's all you guys, but they have to be hard. I don't want easy questions. I didn't just go through the Lincoln Tunnel for easy questions. No, please, I'm kidding.
I was going to say, someone texted me a question. So I'm assuming, of course, I know the answer. I'm going to ask it anyhow. If it takes 15 seconds to put on a Lucas or a auto pulse machine, and you have to stop CPR,
21%.
In other words, if you stop it, you can't do it.
Maybe that's it. Maybe that's why the paramedic trial and the Lynx trial were bad. I wish they were good. I wanted them so much to be good trials. You know, all you got to do is type into Google the paramedic trial or send me an email.
Every 5 seconds.
Yeah, that's the best data we have. So, again, when somebody says to me, you know, you mind just stopping compressions for a second, and a second always means 10 seconds, so I can intubate, I'll go, sure. Mortality's going to go up by 14%. Is that okay with you? Listen, I tell the residents for like in-house for cardiac arrest, I said, I'll give somebody 5 seconds. If you really can't intubate because I'm doing compressions, you got 5 seconds. I'm willing to let mortality go up by 7%. But that's it. After 5 seconds, I say the person who's the team leader has to say to everybody, enough is enough, put a supraglottic airway in and run the code. I have many docs who I've trained who do not intubate at all during cardiac arrest. They only intubate after we have ROSC. And they're doing that in the hospital, and that's best available science. Isn't that pretty good, though? Right? What I do, by the way, with the internal medicine doctors who run the codes in the hospital, we have like 8 hospitals, I say to them, what do I say to them? I can't remember what I say to them. I usually don't talk to them. No, I say to them basically, if you are not experienced in intubating, which most of them aren't, you have to put a supraglottic airway in immediately. You cannot even try to do an endotracheal tube. But if you feel that you have enough experience, a personal decision, because you are certified in intubation, 1 shot. 1 shot, and if it takes you more than 5 seconds, supraglottic airway until you have ROSC, then intubate.
Can you describe pit-crew CPR?
Yeah, so pit-crew CPR, so there's lots of things that are getting in vogue. I'm not in love with the term pit-crew CPR. I love the concept, but pit-crew CPR, I would say it's all these things we're just talking about to improve survival rates. So it's the concept of doing continuous compressions, and it's the concept of not interrupting them. It's the concept of changing who the compressor is and rotating, like, you know, every 2 to 3 minutes. And it's the process of not moving the patient, and it's the process of not focusing on the airway and focusing on the compressions and not interrupting. And when you're bagging, not worrying about if the air is going in, just doing continuous compressions. And it's a process of doing more defibrillation, and especially trying to defibrillate when the machine is analyzing, and not don't defibrillate at that point. So it's all that stuff of continuous compressions, and keep the body circulate and keep the blood circulating. Yes.
I think the problem that we all suffer from is that we're afraid of change and we don't change. We used lidocaine for millions of years, and then it was like, that's bad.
Yeah.
Amiodarone, they said, you know what, the studies amiodarone, the only people that really made the studies are the people that manufactured amiodarone, so that's off. So we become creature of habit, that even when how long it took us to shy away from longboarding a patient,
right,
we'll still do it and say, you know what, but the last slide on the state protocol says, if in doubt, then still, collar and board them. So it's just the difficulty of us pulling away from change, from what we're used to doing.
I mean, I absolutely, plus change is painful for people.
Sure.
And it's because, some of us get educated all the time and believe that we should go to constant education classes for our craft, even though we're not necessarily getting paid to go, and that this is important, and other people don't feel that way. And, if you're just going by how many credits you need to maintain your cert, that's not going to keep you updated. And even the recertification classes are not going to keep you updated. It's all these other things. But I agree, change is something we fight all the time. But it helps me that if I fight, and now all of you guys fight, and we keep just telling other people slowly, and then the next time somebody comes into an ER with a high-flow nasal cannula, and they go, what is this? Or the first respiratory therapist who said, you can't give more than 6 liters, that you're blowing out the sinuses. And then she learned this, and she taught everybody else. I mean, so it's a long battle against the brick wall.
If you had to write the protocol for asystole, what would you give?
Well, listen, Richard Cummings for the last 30 years has been saying, if you show up at somebody's house and they're asystolic, walk away, because the chance of survival is 0%.
Right, now, take that back.
And he's been the medical director in Seattle for years.
Take that back to what we used to give, and we used to give, you know, lidocaine, sodium bicarb, calcium, glucagon, dexamethasone, Narcan, and now we challenge to nothing.
But now you're saying we have changed, because I agree. Sure. We used to put mesh trousers on everybody. We used to do short boards on everybody. We used to take cravats, and I think of all the people, and I'll tell you my mistake. I think of all the people where I climbed into cars with them, and I made sure their head was perfectly immobilized, and I put them on a short board or KED, and then I put them on a long board, and I mashed on their belly because I wanted to make sure they weren't bleeding in their belly, and then we were on the scene for a long time, and we didn't do a rapid takedown, and we get them to the hospital, and their spleen has been bleeding for the last hour. And because they were young and healthy, they never got tachycardic, they never got hypertensive, and now they have 2 liters of blood in their belly. And I go, I mashed on their belly for an hour. They said it didn't hurt, but now their spleen is like a high-grade splenic lac, and I did the wrong thing. And you know, I've learned from that, and I've learned that young, healthy people can have lots of blood in their belly and not be tachycardic and not be hypertensive. I've learned that if the patient looks really okay, get them out of the car a little bit quicker. Don't stay on scene. It's another reason why longboards are just bad things. And and medical patients is still stay and work them, and trauma patients is just get out of there, because the blood that I can't see is what bothers me the most, right? If you're bleeding externally, I'm here and I'm going to help you, right? But if you're bleeding internally, I can't put pressure on that, and I have to get you to the hospital. Yes, sir.
We heard a lot of cool and radical and progressive ideas tonight. I guess you're doing this in New Jersey already. The question is any of this, contra to New York State protocol that we shouldn't, I don't know, double stack, whatever you call it,
right,
shocking and all this stuff, and you got to worry about that.
So one thing, I don't want to make it seem like we're that good, New Jersey. We're a freaking mess. So, we have a lot of issues, and we are a very disjointed system. At least you guys represent a big system. We have 566 municipalities, many of whom don't talk to each other. We have 23 hospital-based ALS systems who all do their own thing.
Like a Jewish family.
We approve things at the state level, and then individual medical directors and administrative directors can do whatever they want once we approve it. So, if you've seen one EMS system, you've seen one EMS system, as the saying goes. So we are not together. I'm putting TXA on the biggest EMS system, which is about half of New Jersey, and some will never do it. We still have projects who don't do RSI because they don't believe in it, or they don't have medical directors full-time. So we still have problems. And listen, New York has got some amazing things that I wish we could bring to New Jersey.
Like what?
like Yankees. I think there's lots of things. I think there's lots of things. And first of all, the fact that you have fentanyl is much better than much of the country. Because well, fentanyl for pain is not a bad thing. I mean, many people can't get fentanyl for pain. Yeah, but pain's a good thing too. I mean, morphine. But whenever you try and create protocols for big systems, I mean, you have excited delirium. Right. Right. So I knew you did before I asked the question. In my state, we wrote our excited delirium protocol 3 years ago, and it hasn't gone through OEMS in my state. 3 years ago. And if that is frustrating us like crazy. So there you go. You want to know how you're better? You have an EDP, excited delirium protocol. What?
We need EDP protocol in New York more than you need in New Jersey.
Let's keep going.
You had that list, the good and bad.
Yeah.
Now the question is, I know, according to the science and according to the studies, that's good, and this is bad, and this has been working. The question is, right now, we can go by that list, we can walk out here and we can say, this is good, so we do it, and this is bad, we don't do it, or is there a protocol that goes against any standing protocol that we have right now?
Yeah, I mean, I'm not the one probably to answer that question, but I can tell you what we can do is we can all start some of these changes today. We can start the nasal cannula change, we can start the bagging change. I think some of that stuff is low-hanging fruit that's good for us.
That's not contrary to...
Right, right. That's up to us at the local level. And again, don't think we're so great, because I'm being honest with you. Because on next Wednesday, I'll sit in a room with the whole state with a bunch of 30 doctors, and they'll all look at me like I'm like, you're doing, ketamine's good now, and I'll go like, yeah, here are all the studies, and they'll go, yeah, well, we haven't read studies in a year or two. And I'll go like, well, this is what we're doing. We're, and the paramedics will be saying, well, we're being taught all this. Why don't you guys know it? And why are you yelling us for not, for doing the latest stuff? I mean, look, we just had a doctor. I get these stories all day long. We gave this drug. We went to the ER. The doctor said we were totally wrong, and they're going to make sure we're never working again. And the one ER, the pharmacist just handed the doctor all the articles I gave to that pharmacist to say, no, you're the one who's totally wrong. And so, it's like anywhere. There are people who are up to date, and there are people who are totally behind the times. But I think it's up to us to go after the low-hanging fruit, because sometimes the change comes away from EMS. The change certainly from EMS, my example in my state, is a change comes from end-tidal CO2, where we're using end-tidal CO2 on everybody, and the hospitals use it on almost nobody. And that's terrible.
Same thing here. You were saying that like this.
Right. And we know for 30 years that in sick people, end-tidal CO2 is really important. Anesthesia has been doing this forever. So why are hospitals not doing it better? I don't have a good answer for that, but they're not, and they need to be. So some of my residents, because residents can be a little radical, they'll go and say, listen, can we borrow your life pack for a couple of minutes to keep measuring end-tidal CO2, because we don't have the ability to do it. Then they'll complain to everybody, and I get to just sit back while they complain. It's kind of fun. But, it slowly generates people from changing. And why are they not changing? Because just like you said, it's the old ideas. But sometimes change is surrounded by cost. And that's the argument I get all the time, that this is very expensive for us to get all new Zoll monitors, or all new this or all new that. But people will say, but you have to do it. But go after the low-hanging fruit. Go after the nasal cannula. I mean, there are several. I mean, the good thing about New York, for sure, is you have several really good academic institutions. Because I read some of their papers, and they're publishing some really great stuff, and that's surrounded by and that helps to push people into the future.
Right, but we still have to work on changing the actual protocol.
Yeah.
And not just going out and doing it.
Yeah. And maybe some low-hanging fruits to bring the articles. Sim has every article in the world, and bring some of the articles and say, listen, I went to this lecture. This is what a lot of people are doing. Why can't we do this? So you're pushing people. I always say, listen, I'm a lucky guy. I work Tuesday mornings seeing patients in the hospital, and the rest of the time I get to play pre-hospital and do EMS stuff. And I get to go to journal clubs and read articles and publish papers. And the truth is, if you're working full-time in anything, there's not a lot of time left in the day to do all this stuff. Yep.
So you talked about the cardiac arrest. The woman went to cardiac arrest 10 times, and then they called you on your cell phone, and you completely went off protocol and told you just to keep pushing epi. Can we have your cell phone?
So this is another reason why my state, New Jersey, is a complete mess. And that's because if you don't know this, we are one of the only states in the entire world, country, I was going to say country, but world, which is 100% online medical control. You guys don't know this? Every time a paramedic unit treats a patient, they must speak to a physician. Do you know that? Let me tell you something. The physicians voted almost 10 years ago to get rid of this system. However, this is in regulations. So this is legislation. So this is why the doctors have no say in this. Even though we voted 10 years ago, it doesn't matter. It's written in the law. We all think this is totally ridiculous. We all know that paramedics have already done it. But because the law says they must call us, so they must call us for somebody with a low blood sugar to give dextrose. They must call us for every single thing. And we know when they're calling, they've already done it. So we try and guess what they've already done. Now, usually it's very easy, but we think this is completely terrible. Now, what we can do is we can a paramedic pronounce in the field?
An EMT pronounce in the field?
Nobody can pronounce. I mean, it's physician order.
So they have to call you to pronounce?
They have to call for everything. There's no scenario where they don't have to call.
Nipples must be sore.
But by the way, the physicians are not happy about this.
I would imagine not.
Right? Yes.
Both in cardiac arrest and in other situations, do you have any preference over IVs versus IOs?
I'm a big fan of I'm a big fan of IO. I mean, if you can get there, and the patient in cardiac arrest, just put an IO in. I like humorous.
Why are you a big fan?
I think it's fast and quick, and I think nobody's. I mean, I think there are many systems throughout the country where their peripheral IV insertion success rate is in the 70th percentile. So an IO is faster if you're in cardiac arrest, and most of the drugs in cardiac arrest are poisons. They don't work anyway. So why focus on giving amiodarone where you have no science behind it, or except, by the way, in kids. Do you know this? The biggest study came out this year in children, and it looked at kids in VFib. The study will never be done again because you don't have that many kids in VFib. But it did it in 30 hospitals around the world, and it found lidocaine to be superior to amiodarone in kids in VFib arrest. It couldn't get enough kids in the pediatric ERs, so it had to include kids in the PICU, like cardiac kids who had VFib. Isn't that interesting?
Last in VFib post vasopressin or epi even. I mean epi, not vasopressin.
Well, vasopressin is no science. But this is what we're really good at in ACLS. We're really good about adding drugs, and we're really bad about taking them away. We know for sure that vasopressin does not work in cardiac arrest. Vasopressin, by the way, is a great pressor. If you're septic, levofed first, vasopressin second. There's great science about that. But by giving 40 units in cardiac arrest, there's not only is there no science, there's science that it hurts people.
Yet it still pushed epi down and said, rather than give epi first, give vasopressin first, and then continue.
So epi, if we have one more epinephrine study in cardiac arrest, I'm going to freak out. So let me tell you what all the literature in the world has said about epi in cardiac arrest. You get more ROSC, right? You get better end-tidal CO2. There's no difference in survival. But despite that, we have epi study after epi study after epi study after epi study.
So what are we left to give it? Humidified oxygen?
What are you left to give?
Yeah.
You're left to give a PEEP valve on your BVM, nasal cannula, continuous CPR, and defibrillation. Well, amiodarone doesn't work. We know that, right? Lidocaine doesn't work except maybe in kids.
And vasopressin.
Bertilium never works, so that's gone. Procainamide doesn't work in cardiac arrest.
Isopro works.
So isopro works, but there are consequences of isopro.
But you can get a...
I give, by the way, early calcium in cardiac arrest because I figure if you're in cardiac arrest and hyperkalemic, might as well give calcium because it makes you sustain a chance of survival.
So one of your units calls you, he's got a fresh cardiac arrest. What do you tell him to do?
Well, they never call me with a fresh cardiac arrest because. So when I say they don't have to call me to ask permission to do things. We have 30 standing orders in New Jersey for adult and pediatrics. But they just have to call me at some point, right? So that can be after they've done everything.
What should I do? The guy just went down, witness arrest.
Nobody's ever asked me what should I do, even at home. My wife has never asked me that.
Not going to give amio, not going to give vasopressin, not going to give...
No, I would. I would give it. Listen, I think if you forget to defibrillate, that's bad. If you forget to give amiodarone, that's okay. Right? I mean, I'm just talking about the science.
Right. So the science doesn't back up.
So the way we do things is once they call the physician, they are off protocol. Right? They're on protocol, but once they call the physician, they don't go back to the protocol. Right? So most people call like after they've done a bunch of stuff.
You know how we work it here, though.
Yeah.
We have standing orders, and then we have medical control options. So we'll call the doc and say, we went through our standing orders, we'd like to now go for these options. Yeah. So we're still pretty much, an online.
Listen, I was a paramedic in Pittsburgh. We never called the physician for anything, zero. We never called for zero. We never called. It's
like Newark.
Right? I actually think the times I've helped pre-hospitally, before all this new PIC crew CPR came out, where I think I'm helping a little bit more now, just for people who aren't like at the bar, because I think people at the bar I don't help that much, but people below it I do. But the number of times I've helped was probably like 5 times in the last 10 years. And I remember most of the cases. One was a patient who had a tramadol overdose. You know tramadol is Ultram, right? And 20% of people who overdose on Ultram are naloxone responders. Right, so this patient was really hypoxic and hypertensive, and they wanted to intubate. And I said, give 10 of naloxone, and they did, and the patient started breathing again. So, and
10 of Narcan? What do you mean carries that much? It's a big deal. 5 of those ampules, high dose.
Because 20% are responders, so I helped that. The medic just didn't know that. That's okay. that's probably what doctors are better at, the multi-drug overdoses and knowing some antidotes. But besides that, medical control does not have to be online. That's ridiculous. Yes?
I guess a two-parter on cardiac arrest. First of all, what are your thoughts on bicarb? Is it better to keep acidotic and shift that oxygen hemoglobin curve?
There's no science in literature about giving bicarb. Some people will give lots of bicarb. The old ACLS manuals used to talk about how many amps of bicarb to give based upon the pH. It was all made up. There's no science whatsoever behind that. If you're talking about giving bicarb for the purposes of hyperkalemia, there's 2 studies. They're both terrible studies, and they both show that your potassium doesn't change much. Even Schreier, which is a textbook of nephrology for the nephrologist, even says if your bicarb is not less than 15, so if you're not acidotic, bicarb does not work whatsoever. Now, if somebody comes in, they're hyperkalemic and they're dying, I throw everything at them, even the non-evidence-based stuff, because they're dying and I only got a couple of minutes. That doesn't happen that much. I mean, if I'm stranded on a desert island with somebody who's hyperkalemic and I can only bring one drug, calcium, and it's calcium, it's calcium chloride, right? You know the difference between calcium gluconate and calcium chloride? Did you carry both? No. All right, good. So there's this old myth that you can't give calcium chloride through a peripheral access. That's totally not true, right? We do that all the time. And on most code cards throughout the world, there's only calcium chloride. Calcium chloride is 3 to 4 times more elemental calcium than calcium chloride. Calcium gluconate is good for topical for hydrofluoric acid burns and stuff like that.
Peds don't get calcium gluconate?
For peds who are hyperkalemic, which is a rare phenomenon, I would still give them calcium chloride, because if you're wrong and they're not hyperkalemic, you're not going to hurt somebody. If you swallow 60 Tums right now, your calcium level won't change. So only if you do repeat doses, right? So when people bring people into ERs because they swallowed a bottle of Tums, you can send them home. People will check calcium levels, but that's not evidence-based whatsoever.
Will you stay around for some questions?
Sure, I'll keep going.
So, just say, those that believe it's come over, those go on stage, Dr. Merlin will stay, and thank you very much.